Welcome to Registry Partners Oncology Coding Break for September 2025 on the topic of pancreatic cancer surgical insights. Let's go into a little bit of pancreatic anatomy. The pancreas is an organ about the size of a hand. This works closely with the liver and the bile ducts that carry the bile. The pancreas releases proteins called enzymes that help digest food and also makes hormones that help manage the blood sugar. It lies behind the stomach and in front of the spine. The pancreas has three main sections. First, the head of the pancreas is an area to the right of the left border of superior mesenteric vein. The body is the area between the left border of superior mesenteric vein and left border of the aorta, and the tail is between the left border of the aorta and the hilum of the spleen. Let's talk about surgical intervention. Some resectable criteria includes the resectable disease, when the surgery in absence of high-risk features without neoadjuvant therapy, or borderline resectable, surgery after successful neoadjuvant therapy to qualify for resectable status. Now, the size of tumor, relationship to relevant structures, and assessment of margins are important aspects of the dissection. This also can increase survival rate for resectability. No arterial tumor contact is also a criteria. Celiac access, superior mesenteric artery, or SMA, or common hepatic artery. Decisions about resectability status should be made in consensus with multidisciplinary meetings. Two of the surgeries that are performed most commonly are the pancreaticoduodenectomy, or the Whipple procedure, which is performed for adenocarcinomas of the pancreas head and unicet, or the distal pancreatectomy with en-bloc splenectomy. This is performed for adenocarcinomas of the pancreas body and tail. Even though part of the pancreas is removed during surgery, there is usually enough left of it after surgery to make hormones and enzymes. Surgical coding for pancreatic cancers. Let's look into a case. Patient presented with abdominal pain. The CT scan showed large pancreatic cysts in the pancreatic tail with inflammation of the stomach and bowels. EGD/EUS had inconclusive results. Surgery was performed due to need for surgical removal of cysts. Surgical path proved to be malignant pancreatic cancer. The operative report had a title of pancreatectomy, distal, robotic assisted. The cyst was noted to be from the distal body, extending into the retroperitoneum along the root of the mesentery. Stomach was completely disconnected off the splenic attachments, and spleen was dissected. Superior border of the pancreas was dissected, and the splenic artery and vein were identified and transected. Distal pancreas was carefully dissected off the retroperitoneum. The pathology report final diagnosis stated pancreas resection, distal with splenectomy, and the synoptic diagnosis stated partial pancreatectomy, pancreatic tail. So with this information, what surgery was performed? The partial pancreatectomy/distal pancreatectomy with splenectomy was performed. What manual is used to find this information? The STORE Manual Appendix A, site-specific surgery codes. And what surgery code is assigned within that manual? It would be B300. The distal pancreatectomy, it removes the tail distal from the center and sometimes the body of the pancreas. It leaves the head intact. It is less complicated than a Whipple. Open approach or laparoscopic approach are used. Sometimes the spleen is removed if the tumor involves blood vessels that supply the spleen. The spleen makes white blood cells and also filters blood. It stores the blood cells and destroys the old blood cells. If the spleen is removed, part of your immune system is affected and antibiotics will be needed for the rest of the patient's life. Surgical coding for pancreatic cancers. Here's another case we can look at. The patient presented with 20-pound weight loss, abdominal pain for 6 months. The EGD with biopsy confirmed malignancy. The clinical stage was T2-NOMO. Neoadjuvant therapy was completed prior to surgery. The operative report showed a pancreaticoduodenectomy. Using electrocautery, lymph nodes were dissected, common bile duct was circumferentially dissected, the tissue anterior to the portal vein was dissected as it traveled under the pancreas, and dissection along the inferior border of the pancreas allowed for visualization of the superior mesenteric vein. The pathology report coinciding showed gallbladder cholecystectomy, a common hepatic artery lymph nodes resection, which were negative, there were 2, pancreatic head, duodenum, and distal stomach. Whipple resection showed adenocarcinoma. The stomach with reactive gastric mucosa was negative for carcinoma, and it shows 0 out of 2 lymph nodes are negative. The synoptic report title was Classic Pancreaticoduodenectomy and Partial Pancreatectomy. The site stated it was a pancreatic head mass and ductal adenocarcinoma. Tumor size was 3 centimeters and confined to the pancreas. Now, the treatment effect was present with residual cancer showing evident tumor regression, but more than single cells or rare small groups of cancer cells. Partial response score 2. Residual cancer was 3 centimeter with evidence of tumor regression, no LVI, PNI evidence, and no lymph nodes positive. So for this, what surgery was performed? Does neoadjuvant treatment affect the surgery code? And what surgery code is assigned? This is a classic Whipple surgery, and neoadjuvant therapy does not affect the surgery code assigned. The surgery code from the store manual would be B352. So a classic Whipple removes head of the pancreas, the duodenum, first part of the intestine, the gallbladder, and bile duct. Nearby organs are removed due to being so closely tied to the pancreas. Surgical approach typically is an open approach. Another option is the laparoscopic, and surgery may take 4 to 6 hours depending on the approach and difficulty. And a fun tip is that Whipple is named after a surgeon with the last name Whipple who refined this type of surgery in the 1930s. Let's take a look at another pancreatic cancer surgery case. The patient presented with obstructive jaundice and pancreatic head cancer by CT of the abdomen pelvis. The operative report title was a pancreaticoduodenectomy. There was a portal lymphadenectomy performed. The suprapancreatic portal vein was identified and dissected to the level of the superior part of the neck of the pancreas. The distal stomach along the pyloric antrum was identified, and the pylorus was tracked all the way to the D1. The transected stomach was repositioned back, dissection carried along the infracolic compartment to transect the jejunum. The root of the mesentery was appeared hard, contiguous with the mass in the pancreas. and this came back positive for malignancy. The entire pancreaticoduodenectomy specimen was carried out/dissected. The final diagnosis of the path report stated a soft tissue excision, root of mesenteric deposit, lymph node resection, and common hepatic artery, pancreas resection, pancreaticoduodenectomy. The synoptic showed a pancreaticoduodenectomy, partial pancreatectomy, and pancreatic head. So with this, what surgery was performed and what surgery code is assigned? This is going to be the pylorus preserving Whipple. This is based on the pylorus being identified and preserved during the surgery. The pylorus preserving Whipple surgery was dictated separately in an H&P, not mentioned here, but that did give another clue to a real case, because the operative report title and the final diagnosis and the synoptic did not mention the pylorus. Within that, the only place that was mentioned as a pylorus surgery was the H&P, and then we can use the information from the body of the operative report to determine what type of surgery was performed. So this would be assigned a B351 pylorus preserving Whipple. Let's talk about the pylorus preserving Whipple surgery. Now the pylorus is part of the stomach that connects to the duodenum. This type of surgery is considered to be a modified Whipple. This surgery preserves the pylorus and the proximal 2 to 3 centimeters of the duodenum. Some physicians believe this surgery helps with food digestion after operation. The surgery may be associated with shorter operative times, fewer blood transfusions, and less blood loss, while other studies show no significant difference in the blood loss. Studies show long-term improvement of GI function as well, while several other trials show similar long-term survival and outcomes as the Classic Whipple. So in the STOR Appendix A, prior to 2024, we had the A300 partial pancreatectomy, an example of a distal pancreatectomy, and then A350, which included the NOS code of the pancreatectomy, the partial, A360 without the partial distal gastrectomy, and then the common Whipple, which is the A370. Moving to 2024 and forward, we have B codes, so there is a difference. The B300 is the partial pancreatectomy, and it gives the example of distal pancreatectomy or subtotal pancreatectomy. And the B350, which is the NOS code, and the example is the pancreaticoduodenectomy Whipple. And B351 clarifies that it is without the partial gastrectomy. That is the pylorus preserving Whipple. And the B352 is with the partial gastrectomy, which is the classic Whipple. So it brings us into how do we pick between 350 and 352? 350 is used when it's not specifically mentioned where the stomach was cut. So here are my references and resources. And thank you for joining the Oncology Coding Break.